to our dearest guests, I want to introduce our team. I'll be the moderator of today's conference. My name is Madonna Achopadze. I'm a neurosurgeon from Georgia, also a PhD candidate and assistant professor in Tbilisi, capital of Georgia. Now, a couple of words about our online education meetings. They have started with Professor Hasan Kamil Sucu, the program manager of neurosurgery department of İzmir Atatürk Training and Research Hospital in Turkey. And it goes on with the contribution of all the residents and all the neurosurgeons who have graduated from the same department. And also neurosurgeons and neurosurgery residents from nearby countries like Georgia, Sakartvelo, Bulgaria, Ukraine, and many others. Now, about the protocol of today's meeting. In order to avoid any voice or noise pollution, all the microphones will be turned off during the presentation of the lecture, but you can ask your questions or write your comments in a chat part of the Zoom program. And at the end of the lecture, I assure you, all your questions will be asked and discussed accordingly. However, mutual discussion is not appropriate for the format of our meeting. And now, I'd like to introduce our guest. It's my privilege to present to you Professor Spence. He is focused on the prevention of the stroke throughout his career. He pioneered the measurement of two-dimensional carotid total plaque area beginning in 1986, and since 1994 has collaborated with Professor Aaron Fenster and Grace Baraga at the Roberts Research Institute in the measurement of 3D plaque volume, vessel wall volume, plaque ulceration, and assessment of vulnerable plaque. His research program focuses on measurement of atherosclerosis by ultrasound for risk stratification, genetic and biological study of atherosclerosis, and for assessing effects of new therapies. He pioneered a new approach to vascular prevention, treating arteries instead of treating risk factors that has markedly reduced risks among high-risk patients with carotid stenosis. Other areas of expertise include the effects of grapefruit on the drug metabolism, vitamin therapy for homocysteine, the clinical pharmacology of stroke prevention, physiologically individualized therapy for resistant hypertension, identification of high-risk asymptomatic carotid stenosis, and the role of the intestinal microbiome in atherosclerosis. His publications include 4 books and more than 600 publications in peer-reviewed journals. He has presented more than 600 lectures in 42 different countries. He is a fellow of Canadian Academy of Health Sciences and American Heart Association Stroke Council, the International Stroke Society, and International Hypertension Society. In 2015, he received the Research Excellence Award from the Canadian Society of Atherosclerosis, Thrombosis, and Vascular Biology. In 2019, he was appointed to the Order of Canada for his contributions to the understanding of atherosclerosis and stroke prevention. In 2020, he has received the William Feinberg Award for the American Heart Association for Excellence in Clinical Research. And now, without further ado, Professor Spence, the virtual stage is yours. You can start sharing your screen. Thank you.
Thank you for this kind introduction. My mother would be proud. So I'm going to talk about management of carotid stenosis, both symptomatic and asymptomatic. And I have references on the slides. You can email me if you want me to send any of these papers that I'll be discussing. My email is here on the first slide, and it will appear again on the last slide. I have no relevant disclosures or conflicts of interest. So the topics that I will discuss today include these. All patients with carotid stenosis should have intensive medical therapy, and lifestyle is important as part of that medical therapy. I'll describe what intensive medical therapy means. Most patients with asymptomatic carotid stenosis would be better treated with intensive medical therapy than with either endarterectomy or stenting, but there are ways to identify which patients could benefit from intervention. Preventing carotid occlusion is not a valid indication for intervention, and most patients would be better treated with endarterectomy than with stenting. So here's one of the studies that showed the importance of lifestyle. Healthy lifestyle in this study of American health professionals, a healthy lifestyle reduced stroke by 80%. And in this study of Swedish men with hypertension and hyperlipidemia, how do I get rid of this? A healthy lifestyle reduced events significantly in patients with hypertension and hyperlipidemia by more than 80%. Now, this process that was mentioned in the introduction called treating arteries came about because beginning in 1986, we began measuring carotid plaque burden. Here's our technologist, Maria Di Sico, who told me one day, well, I asked her how I knew the drawings she was making from one year to the next were reproducible. And she said, well, there's software in the machine. I can measure those plaques if you want me to. So here's how the measurement is done in a longitudinal view of the artery that's magnified, tracing around the plaque with a cursor on the screen and clicking this plaque is 0.18 centimeters squared. So in 2002, we reported that among 1,686 patients followed up to 5 years, we had a lot of events, 94 myocardial infarctions, 45 strokes, 44 deaths, of which 27 were vascular. People have said this is a small study. We had as many events in 2.5 years as in the first 10 years of the Framingham study. It's a powerful population because it's high risk. And we found that the 5-year risk by quartile of carotid plaque area was, as you see on the screen, almost 5, 10, 15, 20%, the 5-year risk by quartile of plaque area. And in the first year of follow-up, half the patients had plaque progression despite usual treatment, and the patients with plaque progression had twice the risk. So this meant that usual care was failing half our patients, and we needed a better approach. So we began in 2003 this approach called treating arteries instead of merely treating risk factors. We treat patients more intensively if the plaque is progressing, regardless of their level of LDL cholesterol or other risk factors. The target of therapy is plaque regression. And here's a description that was published in 2015, a detailed description of this approach, treating arteries. It starts with showing patients images of their plaque and telling them how bad their arteries are compared to healthy people the same age. Smoking cessation, diet, and salt restriction, intensive medical therapy for blood pressure based on renin and aldosterone phenotyping, intensive lipid-lowering therapy, low-dose aspirin with addition of clopidogrel in patients with severe stenosis or other indicators of high risk, anticoagulation, obviously, in people with atrial fibrillation or other cardiac sources, pioglitazone for insulin resistance, and reinforcement of lifestyle changes and referral to a diabetes clinic for diabetics. So here's how I use the plaque measurements in clinic. Here's a man who, age 50, who has a very high carotid plaque area, approximately 95 millimeters squared, and normal at age 80 would only be 80 millimeters squared. So I tell the man, at age 50, your arteries are worse than those of a healthy 80-year-old man. We need to do a terrific job with you, not just a mediocre job. I can write the prescriptions, but it's up to you to quit smoking, follow the diet, and take the medications. And this is very motivating. And here are two studies, one in Wisconsin and the other one in Sweden, reporting that showing patients images of their carotid plaque markedly improves adherence to medication and lifestyle change. Now, what does intensive medical therapy accomplish? Here's our paper in 2010 among patients with asymptomatic carotid stenosis. The proportion with microemboli and transcranial Doppler went from 12.6% before 2003 to 3.7% after 2003. The rate of carotid plaque progression declined from 70 to 19 millimeters squared. And the survival free of events was significantly better among those with microemboli at baseline, even after 2003. Here are the sort of raw numbers on the different kinds of events that happened before and after we implemented this approach in 2003. And on the bottom row, you see that stroke, death, myocardial infarction, or endarterectomy declined from 17.6% to 5.2% in the first 2 years. The risk of stroke declined from 8.8% to 1%. The risk of myocardial infarction declined from 7.6 to 1%. So the annual risk of stroke in patients treated intensively like this with asymptomatic carotid stenosis is only 0.5%, which is well below the risk of either stenting or endarterectomy. So in asymptomatic carotid stenosis, the risk of stroke or death is lower with medical therapy than with either endarterectomy or stenting. And here's a summary by Cosmas Paraskevas of a number of slides. This 3% threshold that's often quoted as being an adequate risk for patients with asymptomatic stenosis is obsolete. It really is obsolete. The risk should be well below 1%. And these are other analyses of this problem. Most asymptomatic patients cannot benefit from endarterectomy or stenting. Here's a paper from the International Journal of Stroke in 2019 in the SPACE-2 trial. The dotted line at the bottom is the patients who were on medical therapy. The risk with both endarterectomy or stenting was significantly higher than with best medical therapy. Now, something that is not well understood is that in patients with asymptomatic stenosis, severity of stenosis does not predict risk of stroke, although there's a recent paper contradicting this conclusion. In NASET, the near occlusion carried a lower risk than patients with less stenosis. Here's a paper from 2015 among patients who went on to occlusion. Percent stenosis did not predict risk in asymptomatic stenosis, but carotid plaque burden, the amount of plaque in the arteries, significantly predicted risk. So how can we identify among patients with asymptomatic stenosis the 10% who might benefit from intervention? Probably the most sensitive way is transcranial Doppler microemboli. Another approach is ulceration on 3D ultrasound. There's some indication that that this progression of stenosis, neovascularization on ultrasound, pretty good evidence that intraplaque hemorrhage on MRI identifies high-risk patients. And we've done some studies indicating that plaque inflammation on PET-CT is associated with recency of symptoms. So here's our study in 2005 in stroke. 319 patients with asymptomatic stenosis. 10% of those patients had microemboli and transcranial Doppler, and their 1-year risk of stroke was 15.6% with emboli versus only 1% without emboli. Here's the Kaplan-Meier survival. And this is from the ACES study by Hugh Marcus. Similar results. They weren't quite as dramatic because they repeated the TCD studies, whereas we only did them once at baseline. But there was approximately a 7-fold increase in the risk of stroke among patients with microemboli in that study. And in our population, the microemboli predicted risk of stroke even despite intensive medical therapy. So here's a paper about ulceration. You see the ulcers here in the 3D ultrasound. And the risk of stroke in 3 years with 3 or more ulcers was 18.2% versus 1.7% with fewer ulcers. And it's very similar to the risk with microemboli. In the future, we'll be imaging vulnerable plaque in a number of ways. And one of the interesting ways is PET-CT measurement of inflammation in the arteries. Here's a paper from International Journal of Cardiology in 2018. Myra Cocker was the first author, in which we found that CD4 staining on the histology of the removed plaques correlated with the inflammation on the fluorodeoxyglucose scan. And we found that patients with recent events had more inflammation than patients with more remote events. Now, in this study in 2015, we found that after we implemented this intensive medical therapy in 2003, the percent of patients in the database who went on to occlusion declined markedly. So there were among the it was nearly 60% of the patients in the database with new carotid occlusions in 2002, and it went way down to nearly zero in later years after implementation of new, more intensive therapy. So the circle of Willis is very protective, and probably works better than most people would expect it to. And it prevents cerebral ischemia at the time of occlusion. So preventing occlusion is not a valid indication for endarterectomy or stenting. Only 1 in 316 patients with a new occlusion had a stroke at the time of the occlusion. 0.3% is well below the risk of either endarterectomy or stenting. So 90% of patients are better off with intensive medical therapy, and endarterectomy or stenting should not be done without evidence of high risk microemboli on ultrasound, transcranial Doppler ultrasound, ulceration, reduced cerebral vascular reserve, and some other indicators of vulnerable plaque, such as intraplaque hemorrhage on MRI. And patients like this that have asymptomatic stenosis should be randomized in trials like the CREST study, CREST-2, with a medical arm. Now, even in patients with symptomatic stenosis, endarterectomy is safer than stenting. So here's a pooled analysis of individual patient data from a number of studies done by Tom Broad and colleagues in Lancet Neurology 2018. The long-term outcomes were dominated by peri-procedural events, but this is the time over 10 years. Patients who had endarterectomy did significantly better than the ones who had stenting. And in the most recent study I think I'm just letting the echo catch up with me there. So here's the data from the ACST study, the peri-procedural outcome and the long-term outcome. So peri-procedural risk was higher with stenting, and that basically dominated the results over 5 years. So most patients are better off with endarterectomy than stenting. And the main outliers and the main people who might benefit more from stenting are younger patients below age 66 in this 2020 study by Tom Broad's group. And this is the meta-analysis in Lancet 2016 by George Howard. Patients who had stenting were worse off if they were older than age 65 to 69. Endarterectomy was not very different according to age group, but there was a clear distinction with stenting that older patients did worse with stenting. So in conclusion, all patients with carotid stenosis should have intensive medical therapy. Intensive medical therapy includes lifestyle change. Most patients with asymptomatic carotid stenosis would be better treated with intensive medical therapy than with endarterectomy or stenting. There are ways to identify which patients could benefit from intervention, and above age 65, most patients would be better treated with endarterectomy than with stenting. So here's my beautiful university where I came at age 17 in 1962. And here's my email address again if you want to send for more questions or with for any of these papers that I've been discussing. So thank you for your attention. I'll stop sharing my screen here.
Thank you, Professor, very much for your lecture, sharing your results. I kindly ask to the audience, if you have any questions, you can speak out or you can write them in the chat, and I will read them for you. My gratitude for information. Before I see any question in the chat, I have one question of my own. As a newbie neurosurgeon, from the study, I got the idea that you'd like to advise us for the conservative treatment rather than for just getting in there with the stenting or with endarterectomy. And I know this is the years of experience that you that speaks for you. But what would be advice for the young neurosurgeons? What are the indications that this is the patient suited for the endarterectomy and no longer conservative treatment would be benefitful for the patient? So what
Well,
would
it's simple. So symptomatic carotid stenosis,
Mm-hmm.
and normally people talk about a stenosis greater than 60% or 70%. I think in future we will be talking about endarterectomy for symptomatic stenosis with less severe stenosis, but with features of high-risk plaque.
Mm-hmm.
And among patients with asymptomatic stenosis, the only ones who should have surgery are ones who can be identified with high-risk plaque by transcranial Doppler microemboli, by intraplaque hemorrhage, by proliferation of ulcers in the arteries, and perhaps some other features of high-risk plaque. But that's the minority of patients with asymptomatic stenosis.
Mm-hmm. And I couldn't skip when I read the introduction for you. There was one of study you participated about the grapefruit and its benefits. Can you tell us a bit about it? I think it will be interesting for the audience.
Oh, it's not necessarily benefits, but we discovered by chance that grapefruit has a very powerful effect on drug metabolism. And there are many drugs that are metabolized by intestinal cytochrome P453A4, CYP3A4. And we discovered, because we used grapefruit juice to mask the flavor of alcohol in a study where we compared alcohol versus no alcohol. So grapefruit with alcohol versus grapefruit without alcohol. And we found to our surprise that the average blood levels of that drug, felodipine, were 300% higher than in previous studies with the same dose. So we went on to do a randomized trial that was published in Lancet in 1991, showing that grapefruit juice, but not orange juice, significantly raised the levels of felodipine. But one of the most important examples in the field of vascular prevention is that simvastatin is an unsafe drug because grapefruit and many drugs that inhibit CYP3A4 increase the blood levels of simvastatin something like 15-fold and can cause muscle problems, rhabdomyolysis. And apixaban, for example, one of the anticoagulants that's routinely used now in the treatment of atrial fibrillation, is also importantly metabolized by CYP3A4. So there are many, many drugs for which the metabolism of the drug is affected by grapefruit and also by other drugs, but by many drugs.
Thank you very much. Dr. Hassan, do you have any questions?
No, I don't have. And I want to thank Professor David. Is there any other comment or I cannot see?
Yes.
Okay.
The chat is not active today. Maybe someone from the audience would like to ask the question of their own.
Okay.
Dr. Nana, maybe you're up to. No, I don't see any. Okay. Bektaş abi.
Bektaş abi.
Thank you, Professor David. Thank you very much for sharing your great experience with us. I am originally from Antalya, and Mediterranean food we are mostly eating. Also, we are always advising people to change their lifestyle and try to follow them in 6 months periods with ultrasound examination. Are we doing right or not? I'm in the same opinion with you for carotid endarterectomy, yes. But sometimes stents may be helpful in some patients. I think we have to work much more with plaques, the formation or the anatomy of the plaques in the future. Thank
Yeah,
you
there
very
are
much.
some patients for whom and stenting may be better. For example, patients who have a very high stenosis, patients who've had previous radiation, perhaps younger patients who don't have a lot of craggy atherosclerotic plaques to push the catheter through. Yeah, the diet's very important. When people talk about the Mediterranean diet, they forget that the good Mediterranean diet that was described in the 7-country study was described by Ansel Keys as a mainly vegetarian diet. So Mediterranean diet, yes, high in olive oil, fruits, vegetables, lentils, beans, nuts, low in animal flesh, and something that I didn't get into today, but I can send a paper about it. People should avoid egg yolks. Egg yolks are not only very high in cholesterol, they're high in a substance that's converted to trimethylamine and oxide, TMAO, that's harmful. So people should use egg whites or other egg substitutes, not whole eggs.
Wow. Yeah, bad news for those who are into egg yolks. But I guess
Actually,
better informed than being armed than
especially Georgian people
yeah.
likes yolks.
And
Yeah.
what do you think about wines?
Yeah,
Yeah.
the evidence that alcohol is beneficial is pretty weak. And many people who drink alcohol get into trouble by drinking too much alcohol. So I don't think it's wise for physicians to recommend alcohol consumption as a way to reduce risk.
Thank you very much, Professor. Sincere gratefulness for your interesting lecture. Thank you, Bekta Shabi, for your question and contribution to our lecture. Dr. Hassan, final.
Also, I want to thank Professor David, and I want to thank everyone who joined us today, this evening. Thank you.
Yeah.
Bye-bye.
Thank you. Bye-bye.
Bye.